Advisory Committee, and would Hillary please call the roll?
Senator Alvarado.
Here.
Thank you. Senator Carroll.
I am here remotely from my district.
Thank you. Senator Higdon. Senator McGarvey. Representative Gooch. Here. Thank you. Representative Gibbons-Prunty.
Here.
Thank you. Representative Sheldon. Representative Wilner.
I'm here in the 35th District.
Thank you. Senator Meredith.
Present in the room.
Chairman Elliott.
I'm here in the room.
Wonderful. Thank you.
Our first item is to approve the minutes from July 21, 2021. Is there a motion to approve those?
Second.
Motion and a second. All in favor, please say aye. Aye. And opposed, no, and the minutes are approved. And so we're having somewhat of a special meeting today. We typically follow the Health and Welfare Committee, and of course they will be meeting next week at the State Fair, so we decided that we needed to have a different meeting time, and that's why we're here today. But there's also a meeting going on involving the Administrative Regulations Committee, and I think a couple of our members are on that committee, and they will be going back and forth to that meeting that I think started at 10, so they've been going quite a while. So our first presentation will be from the University of Louisville Commonwealth Institute of Kentucky. And if Dr. Lisa Creel would come forward, she is the director of the Commonwealth Institute of Kentucky. And if you would introduce yourself for the record, Dr. Creel, the floor is yours, and you may begin your presentation. Thank you for being here.
Thank you, Chairman Meredith and Chairman Elliott, for the invitation to present today to you and your committee. And thank you to all the committee members for your time. My name is Liza Creel. I get called Lisa a lot. It's okay. I'm very used to it. My name is Liza Creel. I am director of the Commonwealth Institute of Kentucky, which I'll pretty much refer to during this presentation as CIK, or the Commonwealth Institute. Today I'll be presenting our mission and goals, the Medicaid policy research that's being done within CIK, and our ideas about opportunities for how we can help the General Assembly and the Department for Medicaid Services craft and inform Medicaid policy. We do this because we all want better outcomes and information about Medicaid so that we can improve those outcomes for individuals and communities and have more efficient use of public dollars in implementing programs like Medicaid. The Commonwealth Institute of Kentucky was established in 2015 within the University of Louisville School of Public Health and Information Sciences. We seek to understand the impacts of delivery design within both the healthcare and public health systems, which are closely connected in many ways. Our mission is to inform policy and practice that will improve population health in Kentucky by supporting collaborative research that improves outcomes and experiences for both patients and providers. Our work in CIK really seeks to impact what many call the quadruple aim. And this is an evolution of the triple aim that you may have heard of. The quadruple aim, which is described in the figure on the slide, and much of the research within CIK focuses on improving outcomes for patients and communities, improving the patient experience within the delivery system, improving the provider experience in delivering care within that system, and exploring strategies that are often driven by policy to reduce cost. I'll mention here that CIK also prioritizes using data and robust data analytics to drive and inform policy and practice change. We seek to do research, but also to translate and communicate our findings and our recommendations in a way that decision makers, you all, can reference and use them. Within CIK, we want our research to make a difference. And we build on partnerships to do applied research that's relevant to improving population health in Kentucky. This applied nature of our research is what makes us of value and helps us establish Kentucky as a leader in doing meaningful and policy-relevant research. Our research is grounded in cross-disciplinary collaborations. Our work in public health is inherently interested in policy to improve the health of populations, and we recognize that complex issues require the expertise of multiple disciplines. We support a network of over 50 Commonwealth scholars from disciplines such as public health, economics, sociology, pharmacy, and public administration. We have established numerous partnerships across the Commonwealth to ensure that our work is relevant to policy decision-making and also implementation. This includes partnerships with governments, both state and local, community-based organizations and delivery systems who may be impacted by our findings, and funding agencies. So why is this important? Well, cross-disciplinary teams really represent diverse perspectives and diverse methodologies. And working in these partnerships helps us do research that's relevant to organizations who deliver care, to the systems that surround healthcare and public health in our state, and the governmental entities that make policy decisions. Now, I'm here speaking to you all, members of the Medicaid Oversight and Advisory Committee, because researchers within CIK are doing work related to Medicaid. Medicaid research within CIK has largely focused on the design, implementation, and outcomes of the program. This work, which I'll share more about in a moment.
I'm sorry, we'll try to mute.
But a 2-year-old and 3-year-old throw their masks in the floor, step on them, and pick them up and put them back on their face. How was that sanitary? You have 2 and 3-year-olds that may sneeze and get.
Okay, I think he.
This isn't
You
much
may
different than
continue
being in
work.
the classroom, so it's just fine.
We're sorry. You
No
you
apology necessary. I
you can
understand.
continue.
This Medicaid research, and I'm going to summarize some of the studies that are happening within CIK. It's especially important here, of course, in Kentucky, because Medicaid provides coverage to many Kentuckians, and Kentucky taxpayers are invested in this program. One way we're able to do Medicaid-related research is through the state university partnership model. And Kentucky is a leader among other states also using this model for Medicaid research. The state university partnership is just what it says. State Medicaid agencies partner with state-supported universities to do research that helps them deliver Medicaid better. It focuses on Medicaid priorities that are identified by the state. This facilitates evidence-based decision-making for state leaders and elected officials. And state agencies can pose research questions and work with university researchers to ensure that those questions are studied and that they inform policymaking. The Kentucky Office of Health Data and Analytics every other year issues a request for proposals specific to research priorities that are identified by the Department for Medicaid Services. Universities submit proposals, and if they're approved, the university provides the dollars that allow the drawdown of federal matching funds to support the work. The actual cost to the state is the administration of the contracts, and systems are in place for how these contracts are executed and how we provide adequate documentation. The partnership nature of this program is what's so unique and valuable about it. The state Medicaid agency can use federal financial participation to support research done in priority areas and leverage existing human and intellectual capital in the state to inform your decision-making. For the universities who also invest in this work, they are able to do research that's relevant to policy priorities in the state, research that really allows us to do what we were called to do, to build on our infrastructure, to do meaningful work to improve the Medicaid program and delivery of healthcare services. We're also able to train the Kentucky workforce, who is focusing and getting education and training to do policy-relevant work. We've been especially thankful for the leadership within the Office of Health Data and Analytics in issuing these calls for proposals, reviewing the proposals, establishing and managing those contracts, and facilitating access to the data that are essential to this work. State university partnership projects within CIK, and there are 5 currently, focus on utilization and health outcomes for Medicaid beneficiaries, opportunities for improvements within Medicaid, and potential cost savings for the program. I want to mention now that the materials that were provided today for you in your packets, they may be virtual, include a couple of summaries for 2 completed projects that were done under CIK. These summaries were developed by the Office of Health Data and Analytics and are also available on their website, along with summaries of other non-CIK projects. Next, I'm going to highlight 4 projects that characterize the policy relevance of the work that we do. The first project I'm going to highlight focuses on type 2 diabetes, end-stage renal disease, and oral health outcomes. This is really a combination of 3 separate projects that focus on one specific population: Medicaid beneficiaries with type 2 diabetes and those with or at risk of end-stage renal disease. It examines physical and oral health outcomes and develops predictive models to identify patients most likely to experience serious complications. So why look at this population? Kentucky has the 4th highest prevalence, of type 2 diabetes in the United States, and that prevalence is even higher among Kentucky's Medicaid population. Given that services for these patients can be costly, and these costs are even higher if there are comorbidities, there's a great opportunity to understand healthcare service needs so that the Medicaid program can target prevention efforts and improve long-term outcomes while reducing cost. There are several key impacts of this project. First, it uses data analytics to understand how long-term outcomes can be improved. Here's an example. The study has found that treatment of type 2 diabetes with certain new drugs can decrease the severity of comorbid conditions. What does this mean for Medicaid? Well, Medicaid coverage of these new drug therapies can lead to cost savings over time because they reduce the likelihood of other expensive treatments like renal dialysis. In CIK, our researchers use data to identify predictors of expensive long-term outcomes so that the state can mobilize resource management and avoid those negative outcomes, thus improving quality of life and saving money. The next study highlights work around the structure of Medicaid delivery in Kentucky, specifically changes in Medicaid managed care over the last decade and the shifting structure of the Medicaid market as a result. The study examines the impact of those market changes on adult Medicaid beneficiaries with 3 types of chronic disease: cardiovascular disease, cancer, and again, type 2 diabetes. Why focus on these populations? Well, death rates from these diseases in Kentucky are some of the highest in the country, and Medicaid spending for beneficiaries with these chronic diseases is high. The study is ongoing, so specific findings are in progress, but the study will provide insight into medical care utilization and contribute to a better understanding around how Medicaid managed care and shifting market structure around managed care organizations impact patients with chronic disease, a high need and high cost population. The next study looks at another aspect of Medicaid delivery, largely on the payment structure side: value-based purchasing. Value-based payment models have been increasingly implemented over the last decade and have been tested to some extent in the Medicare program and by private insurers. State Medicaid programs are also interested, as these value-based models seek to align incentives to improve quality of care while optimizing efficiency in service delivery. In 2018, faculty within CIK and the Center for Health Organization Transformation initiated a study evaluating the readiness of health systems in Kentucky to implement core quality measures as part of value-based purchasing. The study used survey data already collected by the Department for Medicaid Services and also talked to organization leaders to determine readiness for these programs. With a focus on the impact on hospitals, they identified several potential obstacles in Kentucky, including provider risk expectations that may be too high, the inability to adequately understand and analyze the components of these payment models, and lack of interoperable data systems that are necessary for measuring those quality outcomes. Their findings led to several key important policy recommendations for consideration in Kentucky. The summary in your packet includes them all, but I'll mention and point out that their work suggests that the state should emphasize collaborative decision-making with providers on how the program will work, support stepwise implementation to allow gradual uptake for providers, and set clear expectations for implementation very early in the process. The last project I'll highlight is related to alcohol use disorder, something that impacts many individuals and families and every community in the Commonwealth. Alcohol use is the leading substance use among people aged 12 and older. Alcohol dependence is a major cause of mortality and is associated with psychiatric conditions, neurologic impairment, liver disease, and cancer. Alcohol misuse costs the United States over $245 billion per year, and in 2010 costs the state of Kentucky over $3 billion. This study examines alcohol use disorders in Kentucky, as well as geographic variations, risk factors, utilization patterns, and associated costs among Medicaid beneficiaries. Again, this is an ongoing project, but will add to the Medicaid program by identifying strategies for improving outcomes, but also opportunities to reduce cost while improving those outcomes. Okay, so all this work and others I didn't have time to present today, but what now? Why am I here? Well, as I've mentioned several times, we in CIK want our research to matter. Yes, we have academic priorities, but we house a network of researchers that also do this work for other reasons, mostly to inform and impact policy. CIK is committed to informing policy decision-making related to Medicaid through several strategies. Our researchers help identify and understand high-need and high-cost populations and help characterize disparities in access to care or quality of care for those populations. We also do this to help understand prevention strategies that can help people and reduce cost. We also examine the effects of Medicaid policy changes initiated by the General Assembly or the Cabinet for Health and Family Services. This sort of research helps you all know if a policy change achieved its intended outcomes. We are also skilled at data-driven policy analyses on specific public health problems that impact Medicaid beneficiaries or Medicaid providers. One especially exciting opportunity, and why I'm so glad to be in front of you today, is that our infrastructure within CIK supports legislative or agency inquiries related to Medicaid practices. And those inquiries allow us to engage expertise in Medicaid policy and other public health and related disciplines across the state. These types of partnerships can establish Kentucky as a leader in governmental academic partnership to inform positive change to the state Medicaid program. Changes that improve access to care, quality of care, program efficiency, and healthier communities in the Commonwealth. The Commonwealth Institute of Kentucky is a resource for you, this committee, and the larger General Assembly. We are also a resource for the Cabinet and the Department for Medicaid Services. We want to make sure we are answering the right questions so that we can truly inform Medicaid policy, and we need your guidance. We need your guidance, and we need the partnerships across the legislative and executive branches to do this well. Ultimately, this partnership gets us all better information and evidence on how we can impact those elements of the quadruple aim that I mentioned earlier, and that you see again on this slide. Better outcomes, improved patient and provider experiences, and cost savings. The Commonwealth Institute of Kentucky can help you move the needle on key health outcomes and support Kentucky being a leader in Medicaid policymaking and implementation. Thank you all for your time today, and I'm happy to take any questions from the committee at this time.
Thank you, Dr. Creel, for your presentation. I know I appreciate it, and so do the members, and I do have some questions, but I'm willing to yield to our members first before I ask mine. Co-Chairman Meredith, I'll recognize you.
Thank you, Co-Chair, and thank you, Dr. Creel. It's good to see you again. And
You too.
I'll share with committee members that we had a very engaging conversation about a month, 6 weeks ago, And, you know, if you're looking for research opportunities within the Medicaid program, you have hit the mother load.
That's what I like to hear.
Well, and you made the statement about you want to make sure you're answering the right question. I think the bigger issue, are we asking the right question? Let me go back to your first slide, your overview. And we talk about better outcomes. For our Medicaid program, we've been under managed care for almost a decade now. We're still 47th. Those aren't better outcomes. We haven't moved the needle at all. Your next quadrant there is improved clinical experience. I don't think you can find a single provider in the state of Kentucky who's going to say that the current program is working for them, that it doesn't do anything other than increase administrative burden for them and cost. Improved patient experience. I think you'd have a hard time finding people who would embrace that concept as well, principally because the issue is not so much having Medicaid coverage as having access to care, particularly in rural communities, which you and I have talked about. Mm-hmm. And lastly, lowering cost. Heard testimony last year from the cabinet that it costs them 7% to administer the Medicaid program, but that's above and beyond the 10 cents on the dollar we automatically give the MCOs. So we're spending at a minimum 17% of our Medicaid dollars on the administration of the program. We're trying to manage this at the micro level when we need to be at the macro level. Why do we continue to pursue a model of delivery that obviously is not working? We've given it a decade to work. Again, we had this conversation at our last Budget Review for Human Services, speaking with health departments about their reaction to COVID. And we encouraged the cabinet at that time that let's look at a different delivery model. Senator Alvarado, who's tied up in another committee meeting, really, I think, embraces what's happening in Oregon right now, where it's more of a social determinant type model. Mm-hmm. I lean more towards the Connecticut model, which has elements of that as well. But in reading their information, they're able to administer their program for 3% administrative cost. Mm. You know, if you apply those same numbers to Kentucky, we're looking at spending $500,000 on administering a Medicaid program. Where presently we're in excess of, I think it's $2.4 billion. So potential for $2 billion savings, plus improving outcomes, improving patient experience, clinical experiences. Why aren't we looking at that at the macro level, seeing what other states are doing that are obviously having some success with it? And another thing that's missing from the managed care organization model, I think, is the focus on social determinants, which you and I talked about. Mm-hmm. We know 60-70% of the issues with healthcare are based on social determinants, but we're trying to make decisions on this healthcare model within a vacuum that's just healthcare. Again, that's why Senator Alvarado, and I hate to speak for him, but I don't think he'd have any problem with it. And I like these different models because it focuses on the social determinants and makes the funds available within the Medicaid program for that. All those things you've talked about, good studies, but they're treating the symptoms and not curing the disease, if I can speak metaphorically there. Why does no one look at a different delivery model?
So this is actually changing, right? There's actually a lot of some Medicaid programs, I guess I should say, that are looking at that. Some of them you have mentioned. And I think there's definitely opportunity for our network of researchers to help think through and model what that could look like here and build on research that's been done in those other states to try and estimate what those outcomes might be in the state of Kentucky. I think to your point about social determinants, we know that Medicaid coverage healthcare coverage is necessary but not sufficient. There are many other factors that influence ultimately the health outcomes, experience, and cost savings that exist within a program. And we are working, many researchers with NCIK and the University of Louisville are working to do that type of research more and better. And there's definitely opportunities to respond to suggestions like yours. And really align some of the work that we're doing with what could inform your decision making here.
But the problem, I think, is that we don't ask the most elementary questions, and this is part of the conversation I had last time. Why can't we get healthcare providers to go to rural communities?
Right.
Well, immediately you're faced with a payment differential. When there's a lot of talk about equity today, and I think that's certainly applicable in rural communities. I don't think rural communities have been treated equitably. How can you expect a primary care physician come out of their residency to want to go to a rural community where they know they're going to work harder, they're going to see a sicker patient, and they're going to make anywhere from 30 to 40% less than their urban counterparts? Why would they want to do that? Unless you got, a mission, or you're from that area, you got an emotional attachment, it's probably not going to happen. But we never talk about that. We never address that question. And that's part of this overall change in delivery model, that we've got to think different than we have in the past. And wouldn't it be wonderful if you came up with a model that's maybe a hybrid of all these, that let Kentucky be the leader in the nation rather than the follower in the nation? And I think we have an opportunity to do that.
I agree.
I think between Senator Alvarado and myself and probably some other members of this committee, we're going to try to present legislation this next time for a different model. But I think we all admit we don't know what that looks like. It's going to be a gargantuan task to try to put something together, particularly in such a short period of time. But we've got to do it differently. When I came to the Senate in 2016, when I was elected in 2016, Medicaid program was $10 billion. For this next budget cycle, it's going to be $14 billion. Now, we've added more people, obviously, and that accounts for a large measure of it, but it's not all of it. We're not improving the outcomes. We're not reducing costs. We're not improving the experience of the patient or the provider. So we've got to do something different. So that's a challenge that I would give to you folks is you want research, you want to really change this Medicaid program. It starts with the structure, the foundation of the program. And I think it's a better model such as Oregon and or Connecticut or someone. So how can we get you engaged to focus on that?
Yeah, but I would invite you to reach out to us, and we can help identify members, participants in our Commonwealth Scholar Network who can help you with some of that, who can inform that work and the design with their own research and expertise. We're absolutely willing to be as responsive as we can to inquiries like that allow us to truly help provide evidence and data to support the work that you're doing.
Well, I would hope so, because I think until you do that, these other studies that you have done, while they certainly may appear to be important, those are specific to things like diabetes and alcohol. But when you're talking about payer systems, payer structure, Craig Kelly, with my 40 years experience, that's not meant to do anything other than reduce payment to providers, which they can't not sustain any more cuts.
Right.
There's never any substance in those programs. Is we look for a decrease in reimbursement, but we expect an increase in quality, and those are counterintuitive, and they're not going to improve the health of the population to begin with, because we're not addressing the basic issues that have to be addressed. So I am reaching out to you. We want a different model.
Okay.
And we're going to do this pell-mell if we possibly can, but would really like to see a group such as you really take this on and say, yes, there is a better way to do this.
Great.
Thank you. Thank you.
Thank you for the comments.
Representative Prunty.
Thank you, Mr. Chairman, and thank you for your presentation. Your passion is obvious, and I'm kind of dovetailing on Senator Meredith. I was going to ask, how do you choose the proposals of what you study? Because I hope you can stay and listen to the rest of the testimony. One of my constituents, Gretchen Davis, is going to present on her issues with MCOs and the trouble of getting a multi-specialty clinic going and I serve on the SMI task force, trying to serve the severe mentally ill. It's like the payment source in MCOs, and can you do a comparative study of states that do MCOs like Kentucky and other states, such as Senator Meredith has suggested? And I would be glad to sit in on a meeting of conversation of those issues on the side as well. So, but anyway, how do you choose your proposals, and could you do a comparative study, and would you please listen to the rest of the testimony today? So
I'll answer your last question first. Yes, I would be glad to, and I was planning on staying anyways. So thank you for that invitation. So how we choose our studies, the state, the Office of Health Data and Analytics actually issues a call for proposals for those state university partnerships. So I'm speaking specifically to that right now. And they outline research priorities in that university researchers respond to. So in that way and under that program, we respond to a specific call for proposals. Now, we also do other Medicaid relevant research that's not funded or supported through that mechanism. And that often is just aligned with our research interests and expertise. So, for example, and this I think is related to a lot of what you just mentioned. A lot of my work, which I actually did not present today, is around children with special health care needs. And a lot of those kiddos have Medicaid coverage. So I'm really interested in how we design a system that supports their access to care, because many of them are medically fragile and have very complex needs. And that's because that's my passion. That's a population that I want to be healthier and better, and I want their families to be supported. And so sometimes it really aligns with our research interests. Sometimes it's driven by the funding that we can get, but we do always really try to make sure in CIK we are really building infrastructure to not just do the research, but to write the academic papers that are important for our productivity within a university, but also to write other products that aren't published in a paywalled peer-reviewed journal, but are one-page summaries of the work that we've done and the relevance of it to policy and practice change. And yes, we would be glad to talk about a comparative study. Medicaid managed care is really interesting, of course, because states have rolled it out at different times and in very different ways. And there's a growing body of research around that. So I think there's definitely some opportunity there.
Thank you for your responses. And if I just may conclude with some comments. I'm a former physical therapist. I work with kids with special needs, and that was kind of my passion. And I feel like things are all connected. I personally think we need public assistance reform, because I went in many homes where many adults could have been working that were not, that I feel like could improve outcomes, could improve education levels, could improve the whole system. So I think we all need to be working together. And I hope that some of those collaborators are maybe in those fields as well to help. Okay. So anyway, thank you for your presentation, and look forward to future conversations. Thank you, Mr. Chair.
Thank you. Co-Chair Meredith, follow-up.
Yes, thank you, please. You may be aware that we're right in the middle of a 915C waiver redesign. Has the Cabinet reached out to you about providing some assistance in that area?
Not to me personally.
They probably should. Okay. Thank you, Mr. Chair. That's all I have.
Absolutely, I agree. Chairman Meredith, I'm on that 1915C committee. What's the typical time frame for one of these CIK studies? Is that?
That's also largely driven by the funding source. The state university partnership projects are 2 years. They are generally 2-year contracts that start fiscal year, July 1. And will end July 30 of the next year. Some of the others, which may have other types of funding, are driven by the specifics of those funding sources. Some of the things that we do aren't funded and are on our own research time. And those are a little bit faster tracked usually, because we need to get them done. So I think, and I don't know if I'm reading into your question too much, but I think even though a project is 2 years or 5 years or whatever, but is relevant to Medicaid policy decision making, I invite you to still call on us. Just because we haven't published the findings doesn't mean we don't have some preliminary insight into what we're seeing. And so even if a project is just in the middle of its first year, we might have some idea of some patterns or trends that we're starting to see, and we want to respond to your questions and inquiries about how that can be informative.
Following up on Senator Meredith's question about the 1915C Home and Community-Based Waiver Task Force that we have set up to look at possible changes and getting stakeholders together, what would the process be that we would undertake to request that research, and would there be a contract involved and a specific cost, just in the mechanics of how that would actually happen?
So I don't know all of the mechanics. I'm just going to tell you. The first step would be to reach out to me, and I can help pull together the team of people within CIK who can be responsive to that request and who have the expertise in those areas. Not all 50 researchers that are involved are going to be, engaged in every single one of these projects. So certainly, working through the contracting process and budgeting that out would be part of it. The details of that I could certainly find more definition around and how that would work with a request coming directly from the committee. But we absolutely invite the opportunity for those partnerships.
Thank you.
And I will be your first
You're
line.
the first point of contact.
Yes.
Okay. Well, thank you so much. And if there aren't any other questions, we'll Representative Prenti.
Just, you keep referring to a summary. I'm not seeing a summary in my packet. Beside your slide presentation.
There should have been 2 PDF documents.
Okay. Thank you.
You're welcome. And I'm happy to follow up on email with any additional information that you might want in follow up to this presentation.
Thank you very much.
Thank you all.
It looks like our next item on the agenda is school-based Medicaid services. So if Commissioner Lee and Associate Commissioner Kinney are available, are they remote? They're virtual today. Okay. Are they? Do we have them? Okay.
Yes, hi, I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services.
Thank you,
Good afternoon.
Commissioner.
Good afternoon. My name is Robin Kinney. I'm the Associate Commissioner in the Office of Finance and Operations at the Department of Education. And I also have with me today Lindsay Kimbleton. She is in my office, and she is the Federal Program Specialist for our Medicaid claiming program. So Lindsay handles the day-to-day operations and interactions with our local school districts.
Well, thank you very much. And before you get started, I had a brief statement I was going to make related to the topic that we have on our agenda. We have Chairman Meredith and myself authorized staff to send out the audit from HHS Office of the Inspector General, which is entitled Kentucky Claimed Millions in Unallowable School-Based Medicaid Administrative Costs. And I was just going to read what the Office of the Inspector General found in this report, an executive summary. Kentucky did not claim school-based Medicaid administrative costs in accordance with federal requirements. It used an invalid RMS to allocate costs to Medicaid, and it included unallowable costs in its cost pools. In addition, Kentucky claimed these costs without promptly submitting CAP amendments to DCA for review and without obtaining DCA approval. As a result, the $58.9 million, $29.4 million of which was FFP, that it claimed in school-based Medicaid administrative costs for FFY 2009 through 2014 was declared unallowable. And so the recommendations from the Office of the Inspector General, at least the one that gets my attention, is to refund $29.4 million to the federal government, and then some various other technical recommendations. As I understand it, Kentucky has responded to this report, to this audit, and there's some comments as well about how the Office of the Inspector General interpreted the Kentucky response. Do you have any comments to make, Co-Chair Meredith, before we get started here with this presentation?
Just one, Co-Chair Elliott, I was mentioned to Representative Prenti that we initially put this on the agenda because she was familiar with the situation in her home district where providers did not want to contract with the school system because reimbursement was so inadequate. So that was the original genesis for having this as an agenda item. But then this report came to light, and it appears that we've got a program that, while well-intended, is a little bit of a crisis, and maybe we're not prepared to implement. But don't want to be too judgmental on it today, but just that's thinking as to why this is an agenda item for Medicaid oversight. So thank you, Chair.
Thank you, Co-Chairman. And Commissioner Lee, the floor is yours.
We do have a presentation. Should I share my screen, or will the presentation be pulled up on the screen?
Yes, please. I'm told by staff to please share your screen.
Okay. let's
So thank you.
See if I can get this. Can you all see my screen and see the presentation?
We don't. We're just seeing you at the moment.
How about now? Are you still just
No,
seeing me?
we're still seeing you.
Okay, let me try again.
Do we have a handout? We do have a handout, Commissioner.
Okay, I'm sorry, I'm not sure why it is not displaying it. Do I have presenter capability on the end of because it's showing up on mine?
You should, I'm being told.
Okay, so if you have the presentation, I will just go forward with the presentation.
We have it, yes.
In your handout. Apologize for the technology, for the technical difficulties. But basically, slide 1, or I guess it's slide 2 with the background. The Kentucky School-Based Services is a partnership between the Kentucky Department of Education and the Department for Medicaid Services. This program allows schools to receive federal funds for certain services provided to Medicaid eligible children in schools. Now, the schools enroll as a Medicaid provider, and the services are carved out of managed care. These services do not go through the managed care organizations. The costs are based on cost-based. So not all schools are paid the same. For example, these are cost-based services, and the schools submit cost reports at the end of a year. And the Department for Medicaid Services, contracts with an organization to determine the actual cost of providing those services for each school. So schools are not paid on a fee schedule, for example, like most providers are. Schools pay the state match for this service, and they pay approximately 30% for direct services, which are those services provided directly to children in a setting, for example, speech therapy, physical therapy. They would pay 30%. The program does allow for administrative claiming, and which is a 50% match. So administrative claiming, for example, is going back to the random moment study referenced in the OIG audit. We do a random moment study for schools, and in that there's a contract that, and then we have a company that contacts schools, and they'll find out, for example, what percentage of time an individual is devoting to Medicaid services. And it could include, for example, determining eligibility or assisting with eligibility and outreach. So the administrative claiming piece has a broader pool of individuals for that program. Going to slide number 3, coverage provisions. Services. Sorry, are y'all hearing some feedback? Or is there?
We are hearing some feedback. I don't know where this is coming from. Apparently it's on your end, so I don't know.
I can mute my and see if it's on my end. And Robin, if you want to take over some on slide 3, I'm not hearing the feedback now, so
right,
I'll just go. I'm sorry.
We're not here.
Okay.
Yeah.
So slide 3, coverage provisions. Typically, services are outlined in a child's individualized education plan, which allows states to draw down those federal funds to pay for school-based services as required in the Individuals with Disabilities Education Act, or IDEA. So basically, IDEA states that children who are in a school setting and receive not just Medicaid, but any child should have an individualized education plan to help them be successful in their school environment. When Medicaid is involved, those schools can bill Medicaid for those services and draw down those federal dollars. The service must be provided in the school and outlined in the child's IEP. In April of 2019, we expanded care in schools to allow them to provide services outside of a child's IEP and can include any service covered by Medicaid as long as the appropriate individual or provider is qualified to deliver that service. And both the expanded care in school and the IEP services are included in the administrative claiming. Administrative activities, as I said before, are necessary for the administration of the services as outlined in the Medicaid state plan and can include outreach and enrollment, care coordination, referrals, and transportation. And again, this is a broader pool of individuals who receive those services, who can deliver those services in the school. So it's a broader than just, for example, the speech therapist. It could include an administrative person in the office who is helping with eligibility, for example. All children who are enrolled in Medicaid and K-CHIP are eligible to receive school-based services with the exception of approximately 46,000 children who are enrolled in our separate program portion of K-CHIP. I could get into a little bit more detail, but that gets kind of complex. But basically, I think the main thing to understand is there's about 46,000 children who are exempted from this program, and we would like to make some policy changes that would allow those children to be enrolled in that, enrolled in school-based services and receive the same benefits as the majority of our other children do. School-based services are covered under the early and periodic screening, diagnosis, and treatment portion of the Medicaid state plan. And that's one of the reasons that those 46 children enrolled in their separate portion of K-CHIP are not eligible, because they are not eligible for those EPSDT special services in their separate program. And I will turn on slide 6, I will turn this presentation over to my colleagues in KDE, and they can discuss the school districts participating in school-based Medicaid.
Lindsay, I think you're on mute.
Sorry about that. Okay, so currently in Kentucky, we have 171 school districts. Out of the 171 school districts, 163 schools participate in the school-based Medicaid program, which means our participation rate is currently at 95.3%. And I will give you back the floor, Lisa.
Thank you, Lindsay. So slide 7 shows the amount of claims paid, children served, and schools that billed for direct services by fiscal year since 2009. Don't think I need to go over each line item there, but you can see in 2020, we had a slight drop from the 2019, and some of that was due to COVID. State fiscal year 2021, I would like to point out, is not complete yet. We do not have all of the data in that chart. And again, slide 7 just depicts the procedure codes that were delivered. You can see the top procedure code that was delivered for individuals with speech therapy. So again, I don't think I need to go line by line, but this just gives you an idea of the number of children who receive services, the services they receive, and how much we have paid for those services. And then if we move on to slide 9, again, that's just a depiction of the same information, but this is by paid, the amount paid. And this information includes all of state fiscal years 2009 to 2021. So again, you can see that speech therapy is the #1 paid service. Moving on to slide 10, we get into the administrative claiming portion of the information. So again, don't think I need to go slide by slide. Again, 2021 is not complete information. So that gives you some idea of the administrative claiming dollars that come into the state. Again, this is a 50-50 match. So these costs are split between the schools and the federal government by 50%. So again, this just allows those states to bring in those extra federal dollars so that they can maximize resources that they have to take care of our children in schools by delivering these vital services. And I think slide 11, I will turn over to my KDE colleagues about the school districts overcoming barriers.
Thank you. As I previously discussed in slide 6, We have most school districts participating in the school-based Medicaid program. However, we do have 8 districts that aren't currently enrolled in our program. Why are these districts not enrolling when they are already providing the services within our schools? There are a few barriers that are hard to overcome in this program. One being often school districts use IDA money to fund their therapists. IDA money is federally funding, so you can't pay your therapist out of federal money and then request that your therapist request Medicaid back. Using federal funds to employ a therapist, then requesting reimbursement would be considered double dipping, which isn't allowable. 2, starting this program requires extensive work. It often requires that you hire an employee that just manages the program. Districts often don't have the manpower to get the program up and running. And 3, some districts just don't have enough students that are billable to make it worth their time. However, now that expanded access is part of the school-based Medicaid program, we are optimistic that districts that currently don't participate will soon enroll. At the beginning of our yearly enrollment, we reach out to all the districts that aren't enrolled and encourage them to participate in the program and give them updates about our program. If you'll go to the next slide. Both agencies collaborate on this program to ensure success for Kentucky school districts. The Kentucky Department for Medicaid Services is the regulating authority for the school-based Medicaid program. They provide KDE with program policy for the school-based Medicaid program. KDE then provides guidance to all the Kentucky school districts. As a team, we provide up-to-date data on our websites. Our program guide is ever-changing. KDE provides annual training. Districts can also request trainings throughout the year. We often provide smaller, more intimate trainings to groups of therapists where we have more of an open discussion about the program. KDE and DMS working together is crucial for this program and the districts. Our goal is to ensure that we provide excellent customer service to districts and accurately implement the school-based federal policy as a team.
Shit, I'm way behind. It's been going on an hour.
Could you mute your Representative Sheldon? Mute your Zoom. Thank you.
All right. If
we
you can
apologize.
No worries. If you can just go to the next slide. So the obvious answer to increasing the participation in school-based Medicaid is getting schools enrolled in expanded access. As I previously discussed, this is the program that only requires medical necessity. As we process applications for the upcoming school year, we have seen an uptick in districts opting to participate in this part of the program. This part of the program ensures that all students' needs are addressed with or without an IEP. So I'm going to give you a couple examples of what expanded access could potentially bill for. A school conducts a screening for all of its students. The school may be able to bill for Medicaid eligible students. And another example would be Johnny goes to see a nurse. Since he has Medicaid, the school may be able to bill for his visit. As districts become more comfortable with this part of the program, participation in the school-based Medicaid program is sure to increase. All right, Commissioner Lee, I'll pass it back over to you.
I think that actually concludes our presentation. You can see this as a partnership between Medicaid and the Kentucky Department for Education that allows them to maximize funds and resources so that we can deliver vital services to children in schools. Again, going back to the cost report, as you did some of the costs, for example, the administrative costs related to this program would be higher in those districts that have more Medicaid enrollees than those districts that do not. And so I think, again, this concludes our presentation and we'd be more than happy to answer any questions.
Thank you, Commissioner. And I know that Co-Chair Meredith has a question.
I do, Co-Chair Elliott, and you'll have to forgive me. I think when we first became aware of this program, very supportive of it. The more we can provide services within the school system to help our children, the better. But you have to excuse me. I guess I'm just a dumb old country boy. I don't really understand this delivery model. In your first slide, you say that this is carved out of managed care, so the MCOs are not involved whatsoever. correct?
Correct.
So who administers the program? Who has responsibility for the students from a medical perspective?
So it's a collaboration between Medicaid and the schools. We have regulations, the Department for Medicaid Services we have regulations that govern the program and who is eligible to deliver the services. So when we think about school-based services, for the most part, up until 2019, it was those services that those children needed in order to be successful in school. Most of the services, for example, speech therapy, physical therapy, those sorts of things that can be delivered in school. It did not include medical service. Well, it could include some medical services if they were outlined in an IEP, but it didn't include, for example, just a nurse giving a shot until recently. So those types of services, you're looking, am I confusing you, Senator Meredith?
You are. I guess
confused.
More elementary. Yeah. Where's the coordination of care here? If a child is receiving services through the school system, but also is a patient of the local pediatrician, how does the pediatrician know what's occurring with the student / patient, and who's responsible for the outcome, the improved health of the student?
All of our physicians and providers have access to medical records for all of their patients under KY HealthNet. They can go in and look at that. Now defer to KDE on the actual services that are delivered in schools for the IEP. And I think that there's two conversations that we would need to have. One is for the IEP and one are for the expanded care in schools, which is what you, Senator Meredith, I think are questioning. So expanded care in school will allow, for example, behavioral health providers to deliver services to children in schools, and the school would be able to bill for that service. The coordination would then come into play with those providers. They can go into KY HealthNet, see what's been going on with those members, what services are being delivered. I can defer to KDE on the actual IEP services.
Well, let me ask more, and I'm struggling with the question. It's kind of evolving as we're having this discussion. But again, the Medicaid Managed Care Program was developed to manage the care. That's why the MCOs are given these contracts. Why are we creating an entirely different system to provide these services? Why couldn't that be done with the MCOs by working directly with the school systems and not creating a new bureaucracy for this program?
The school-based services were carved out of the Medicaid Managed Care Program because of the financing mechanism. The schools actually pay for the state match on that on the services. And the services that were delivered in the school-based setting, typically prior to us expanding the services, were only limited to IEP services, which were actually not part of the managed care array of services, because some of those services in the IEP are not covered by Medicaid. Are not covered by managed care organizations. They're specific to the school-based setting.
Are the providers paid on a fee schedule?
The school-based providers receive services based on the actual cost of delivering the services. It's a cost-based methodology. We do a cost settlement each year, and each school district or each school services are different. It's not a set fee schedule for services across the school-based setting.
Well, I still struggle with seeing this as an efficient, effective model for delivery, and really don't understand why we're doing it outside the MCOs, but I don't want to belabor the point. Maybe it's a conversation we have later, but it goes back to Representative Prunty's original question is, in her district, the payments that school systems are offering the providers are so low that nobody wants to participate. So how do we address that?
And I think KDE, would you like to weigh in on that? But I think that there are some school services, for example, that contract with FQHCs, CMHCs to deliver services. And in those instances, those FQHCs and CMHCs bill Medicaid directly. And they are part, those claims do go through the I'd have to double check. Now I'm walking around this and getting confused myself, Senator Meredith. But some of the schools will contract with CMHCs and FQHCs to deliver those medical services for children. So there is the coordination of care in that model. And KDE, if you'd like to weigh in a little bit more about the specific services and how the model works and the coordination of care with providers in the community.
Before the answer, just clarification. So KDE is the administrator of the program?
Kentucky Medicaid administers the program. KDE oversees the providers and makes sure that the providers do the billing. We actually, Medicaid oversees the program itself.
Then going to this audit that says that they paid too much in administrative cost, who was the beneficiary of that?
KDE received the funds from the federal government. So the Medicaid pays KDE for delivering the services. And then the schools draw down the federal funds.
Yes. And so eventually it goes to the schools in the drawdown of federal funds. Senator Meredith, if I could ask Lindsay Kimbleton to jump into this conversation. Lindsay is our federal program specialist that works directly with our local school districts and providers. And maybe Lindsay can give an example of how that works when we are trying to provide services to a student with an IEP.
So to provide student or services to a student with an IEP, that is a contract between the school district, and that's the IEP is basically a contract. It is legally binding within the school district. The school has to provide those services. That is not, it doesn't matter if, where the therapist comes from, but the school is responsible for getting that child the services required. So unfortunately, KDE does not set the rates. About the rate part, that would be upon the district's individual hiring authority. They get to set the rates. That is not a standard price, but an IEP has to be, the needs that are in an IEP must be met by the school district. So they have to get a therapist to provide those needs.
Well, in essence, you're saying that KDE is a managed care organization specific to this patient population.
You could look at it that way. I think they are the agency that makes sure that those kids receive the services that they are required to receive, as Ms. Kimbleton said, through the federal government requirement outlined in IDEA.
Well, I'm going to be very candid about this. I don't think that KDA should be in the healthcare business, and I'm not sure I've got confidence in their administrative abilities to administer this program. And I wish I had this kind of awareness before we got into it, but I think we've got some real issues they're going to have to look at a lot more in-depth detail. This is a little bit disturbing, particularly this Office of Inspector General's report regarding the unallowable administrative costs. There's a lot of question marks here, and I'm very concerned. But, Mr. Chair, that's all I have at the present time.
Mr. Chair, may I respond briefly to Senator Meredith's comments?
Sure, you may. Go ahead.
Thank you very much. Senator Meredith, certainly it is concerning whenever you get a report from the Office of Inspector General of really any agency, and Health and Human Services has issued this report. I will share with you at this time, I think, and I'm not going to speak for Commissioner Lee, but on behalf of the Department of Education, as we work with Department for Medicaid Services, we really we are in strong disagreement with the findings made by the Office of Inspector General, and we have prepared a response to that. Unfortunately, it appears that many of our responses and the facts and information that we provided to the Office of Inspector General were not adequately weighed. And so we do intend on continuing to fight this with the help of Department for Medicaid Services. I will note that other states find themselves in similar positions from prior audit findings from the Office of Inspector General of HHS. We are not alone in this endeavor as we try to work through some of the logistical concerns. I would also say the amount that they are requesting for a refund, we don't feel appropriately matches really the scope or breadth of the errors that have been identified. So we always are searching to improve our program, and constructive guidance and direction to improve our program, of course, is welcomed, and we've made some changes as a result of some of their findings to improve that program and work back through CMS. However, we really do disagree with the amount both that they have charged that should be the refund, and really tying that to the scope and breadth of the findings they receive. So I think we will continue to kind of proceed on this path through CMS, which is our understanding, again, working with our state Department for Medicaid Services, has the ability to look at that findings and the requested action on behalf of Kentucky. And then if that doesn't yield sufficient results for us, we will consider other avenues of appeal. So I just, we take the report from the Office of Inspector General seriously. We have worked for the constructive pieces of that to improve our program, and have already started turning that around through our training and written materials. But just want to state that we hear your expression of concern, and we will continue to work on seeking an amicable and good resolution for the Commonwealth of Kentucky.
Well, thank you, but I'm not sure you really hear my concern. I think this is another classic example of the healthcare delivery system being so fragmented that we never accomplished the end goal that we originally intended. And we've created a whole new bureaucracy for this program, which again increases cost. Just the fact that it's reimbursed by federal government, I don't think is sufficient reason to say we need to head this direction. But healthcare system's too fragmented. There's no oversight. There's no accountability. And just conceptually, I have a problem with the program.
Representative Prunty, you're recognized.
Thank you, Mr. Chair. Quite frankly, I feel like the carving out the MCO supports your case to look at a different model of care. But I think that when this was created, and I was a former PT, I provided services for IEPs in schools, so I've been a part of the system. And to be able to provide services in the school would be better for the student because they don't have to leave school and go to get those services. It's more efficient. They don't miss academic time in the classroom. I can see all the benefits of the program. And my questions were related to the OIG report, in the sense that I know my husband was in private practice for years, and you can make mistakes in billing and be accused of creating a mortal sin when really it might not be as bad as this sounds. And so you've sort of addressed that, I think, Ms. Kinney. And so I was going to ask how much of this is as bad as it sounds, or, was it mistakes just learning along the way? And I guess the question is, does the KDE, are there any personnel involved in the school system that bridge the healthcare system so that there is somebody who understands it in order to, I can't imagine being in a school trying to bill for healthcare services, not understanding that system. Are there personnel in place that understand it, that can help do the billing? But also, to me, there could be a good win here for everybody, I think, if you get someone who understands it, but also look at that different model of providing the care. But anyway, I guess I asked 2 or 3 questions, and just if you can just respond, I'd appreciate it.
Thank you very much for the questions. I think you are correct when you state, when we see a very large number, like as stated in the OIG report, when you actually get into the specific and details of what has been said and determinations and findings that were made are not really as egregious as the dollar amount suggests. We have identified that there are some errors that have been made, and in our response, we have offered a certain dollar amount that we would think would correlate with those specific errors that we agree with. But it is a very small percentage compared to what the OIG is suggesting. So basically, they took a very small error and really extrapolated across a period of time to all things that happened in that period of time. So we do disagree with the findings of the Office of Inspector General, and hope that we will have a better audience with CMS as we try to work through this. I'm going to let Lindsay jump back on again and talk about, we very much agree from the Department of Education's perspective, because what we do most of the time is deliver educational services for our students. But as you know, many times we are tasked with other things to really support the whole child. And so we view this as an opportunity to really support the whole child. It's an opportunity to have our kids at school and receive these services at school instead of taking the time away from school to go to an outside provider and come back in. So while that still happens, this opens an opportunity that really increases our time that we can receive and children can receive those instructional services. So that's very valuable to us from the educational standpoint. I'm going to let Lindsay jump on and kind of talk about how that works as a practical matter. So maybe talking about some of those services that might be delivered in our school setting that a student doesn't have to leave our school building.
Okay, thank you, Robin. So we provide all different services as we have previously discussed in our slides. We provide behavioral health services, psychological services, nursing services, speech services, OT, PT. I mean, the list goes on. And we also can provide O&M services. So a child does not have to leave the school setting in order to receive those services throughout the day. So a child can receive speech in the morning, and then that afternoon, if he needs some therapy, he can see a school therapist. So that is very beneficial for the child. And as we talked about before, often a child may have speech in their IEP. And with this expanded access that we've now brought on board, that child may have not had, behavioral or psychological needs in the IEP. That's very rare to see. So now we are able to provide, therapy sessions, even though that's not like necessary per legally on the IEP. And now,
I'm just going to interrupt you if you don't care. I understand those services that are being provided, and that's great. I get that part. My question was, who's been trained to bill at the school level? I get the services because I used to provide them, and I get the benefit of not having to leave the school. I'm just wondering who's been trained to do the billing.
So here's the deal. So every school district has a billing agent. They can either choose to bill within their school, which there was only one school and one district in the state that actually chooses to privately bill. And then they bill with other agencies. So when you sign up for school-based Medicaid, you enroll with a billing agent if you decide to participate in the fee-for-service, which is this PT, OT, and all those services. So that would be KSBA is a vendor. Also, we have PCG, who's a vendor. And then we have a vendor named Info Handler. And those are the biggest vendors in the state. And they do all the billing, and they have background, and they have certifications in billing. So they know, the rules. They're coders, basically. They're billing coders. So they do back them and, take care of the school districts in that matter.
Okay. Thank you, Mr. Chair.
Okay. Sorry about that.
Thank you. With respect to the audit, and any of you can answer these questions, is there more of an appeal available here? Because it seemed like in some of the comments that were made that there is an anticipation that this isn't a final decision. So is there additional appeal available based upon these findings?
Well, this is Lisa with Medicaid. The HHS OIG does the report and they send it to CMS. So we are in discussions with CMS. We did disagree with the findings of the HHS OIG report, and we are now August 6th, we sent a response to CMS. We'd be more than happy to provide this committee with a copy of our response, in which we discuss the reasons that we do not agree with the HHS OIG report. And we are going now in conversations with CMS to see how what sort of options we have going forward. But again, it's in CMS's hands right now.
So I want to read a paragraph to you and get your reaction to that. In written comments on our draft report, Kentucky generally disagreed with our findings, which I know you have said, and it did not It did not specifically address our recommendations. It agreed with certain elements of our findings and described actions it had taken or could take to address them. However, Kentucky did not agree with our findings that its RMS was invalid, that support staff costs included in its cost pools were unallowable, or that its cap amendments were not promptly submitted for approval. Kentucky did not provide any additional documentation with its comments, and nothing in Kentucky's comments warranted changing our findings and recommendations. What is your reaction to that? Because it sounds like that you wouldn't agree with that from just reading into the comments that you've made, but has this appeal that I think you've offered to forward that to the committee, has that been altered at all? Because it sounds like here the OIG is saying you didn't really respond to the findings.
So I think there's somewhat of my reaction is there's somewhat of a disconnect between HHS and OIG. They are two different organizations. CMS, during the time frame that they audited, the Department for Medicaid Services was in close contact with the Center for Medicare and Medicaid Services, and CMS approves our state plan amendments. We had been in talks with them about our RMS. They had been approving. We have documentation that we had submitted to show that we had been in talks with CMS about approving our random moment study. So we provided that information, and I'm not sure, again, HHS and OIG different than CMS. So I think there's just some disconnect between those two agencies, and they were not aware that we were in talks with CMS. Therefore, they saw our RMS as not being approved when we were in discussions with CMS to obtain approval.
In I guess a worst case scenario here, if the money does have to be refunded, what is the process to repay the money? Will it have to be a lump sum? Where will it come from? I know that's crossing the bridge before we get to it, but I like to do that sometimes. And
we would discuss. Oh, I'm sorry.
But what? I'm sorry. What is that process?
We would discuss with CMS. It's possible that there would be a payment plan. And the funds would come from KDE.
Okay. Representative Wilner, you're recognized remotely.
Thank you. Thank you very much. This is a really interesting conversation. I've got a little bit of whiplash because I feel like we're going back and forth between the audit issue and the Medicaid in schools issue, and those are two important things. Representative Prenti actually raised some of the issues and asked some of the questions that I would have asked, but just a quick clarification on the audit and then another question, if that's okay with you, Mr. Chairman.
Yes.
Thank you. I just wanted to clarify, I think that the years of the audit were 2009 to 2014. Is that correct?
That is correct.
Okay, so we're looking at information from several years ago, and it sounds like I think what you're saying is that there have been some changes in the way that you're proceeding on some of these things, so that we're not going to see this ongoing. And if they were to audit between 2015 and the present, we might not see these same concerns. Is that correct?
Yes, I believe that's a correct statement.
That's correct.
Okay. The other question that I had for you, not on the audit, but just on Medicaid services in schools generally, this is something, the expansion is something that happened under the previous governor. I was, very excited that this was happening, that kids would not have to have an IEP in order to have behavioral health, psychological services, other kinds of needed services without, as you and Representative Prenti have pointed out, without having to leave school. So if we're assuming that this is on track and that this expansion is a good thing, what barriers are currently in place to kids being served? Is it the capacity within the schools to manage the billing, or are there other barriers that would keep kids from being able to fully benefit from these types of services?
Well, I think I'll start from Medicaid and then I'll let KDE join in. But again, 2019 was just a short while back. And we, as you said, this was started from the previous administration. We think that the expanded care in schools is something that can greatly benefit our children. And so we were having stakeholder meetings. We had individuals from KDE, the cabinet, both Medicaid and our public health, Department for Public Health, various stakeholders, advocacy groups, provider groups to talk through some of the things that we need to do. And I think that right now some of the barriers are, of course, COVID happened, and we could not continue some of those stakeholder engagements to work out some of the issues that we were finding. For example, one item of topic was parental consent. Parents do have to give consent for these services. So I believe what we need to do is continue to have those stakeholder engagement meetings, and as Senator Meredith has pointed out, make sure that there is coordination of care with the providers in the communities and the schools to ensure that we're doing the best thing for the children, and to break down some of those barriers so that we know exactly what services are needed in each district. And I think that I will let KDE add any commentary they would related to what they believe the barriers are.
Commissioner Leah, I think you did a really good job summarizing what's going on. You know, the biggest thing from the Department of Education's perspective right now is we need kids in school. And so having kids in school will allow us a better opportunity to really grow the expanded care program. Keeping them in school, learning, and having access to these to the medical and emotional and behavioral avenues that we have to treat, but they got to be in school first to do that. So that's a big hurdle for us right now with COVID continuing to kind of control a lot of situations for us.
Thank you very much.
Dr. Alvarado is recognized. You've had a long day.
Oh, yeah, it's been
thank you for being here.
Very long. No problem. Thank you all. I may have missed the earlier part of the presentation, but you know, I look at this audit. This is good old-fashioned rack audits, is what we call them. You know, the Medicare rack audit is what it is ultimately, and we get these through Medicare all the time. They'll come in, review so many charts, they'll find enough errors, they'll extrapolate the data and say, oh, you owe us this much, and it may only be the amount that they've seen. And these are the bane of medical existence for most providers. So welcome to the club, I'd say, to KDE, because most of us as medical providers deal with this, and it's very annoying. So I understand wanting to fight it and saying it's probably not as big, but what they do is they'll take a small amount of information. I saw that you guys were arguing that it wasn't weighted properly in your comments, and I understand those. So I'll be curious to see how this rolls out when it all comes out in the wash. Two things I wanted to just cover. So I was going through the presentation. You cover a lot of nursing issues. We've always been pushed for nurses in every school if we could. I'm curious how many of our schools now, or at least school districts, have nurses in our schools. That's the first question that I have.
Senator, I don't have that number. I can certainly try to get that for you. Either, first of all, district. We have some districts that have nurses that actually share across schools, but I can also try to get that information for every school for you. I don't have that information with me today.
I'm just curious if the school districts have them, because that'd be great. Again, they can just be triage, if anything, and I know they probably don't provide as much detail. The last thing I'm curious about is, you know, talking about the model of care, obviously being a pediatrician, having had an office, would be telemedicine. And the thought of doing that in our schools is to have a telemedicine station somewhere, and that if a child is sick, a nurse could, you know, if there's a nurse available or someone who could at least have a provider log in, take a look at that child, and provide some kind of service to determine, do they need to be seen in the office? Hey, look, that can be handled there at the school. They don't have to leave. It would help cut down, you know, again, keeping kids in school. And that's been talked about before, as telemedicine being that opportunity. Are we looking at that to have a telemedicine station in our schools, and then allowing our primary care providers to log in from their offices or from wherever they're at to provide that care, to be under that current MCO model that we have, to provide that kind of global care? I mean, we can't do, you know, I guess you could do some therapy that's possible around some of that, although it's always better to be live. But I'm just curious if that could be expanded to where we're not having to use the dollars for that. If you've got a provider who's getting paid for that service, can do it through telemedicine. Are we exploring that idea? You're muted.
We are using telehealth in schools right now. I'm going to let Lindsay kind of weigh in on what she's seeing as that growing trend. It's really been beneficial for a lot of our school districts to be able to, again, keep that child in school and also have the remote access to the medical providers that may not be there. Lindsay, can you share a little bit what you see as the growing trend of telehealth?
Sure. So telehealth was pretty much non-existent in school-based Medicaid up to last year. When COVID hit, it completely changed the game. We use telehealth all the time, which is fabulous for Eastern Kentucky because they have a hard time getting a lot of providers out there. So this way, kids are receiving services across the state with or without having those providers within the school. Right now, we don't have any telehealth stations that I'm currently aware of, but that is a fabulous idea, and that would be a great thing for several school districts that struggle with Wi-Fi.
We've just gotten a big infusion of cash from the federal government. I know a lot of our schools are sitting on that. That might be worth a consideration, particularly in rural areas, is to say, hey, yeah, we can provide some of these services you're mentioning here through a separate fund, but if you've got a primary care provider who may not, like to Senator Meredith's point, may not have all the information, they could log in, have a visit, receive information and details about that patient's care. It might be worth looking into that, just to have those in school settings. Again, it would help reduce having to run to offices. And again, more people are becoming more comfortable. And we're fortunate here that we passed a pretty good bill to make it really broad to allow that coverage. So I would encourage you to look into that, maybe consider using some of those funds for that purpose. Thank you.
Thank you. I have one final question related to the audit, and then we will move on to the next topic. I know there's been reference made to vendors related to the payments, and this is a question you may not be able to answer, but you're willing, or we're willing to have you submit the answer in writing. Is there any liability potential to those vendors that were involved in the payment services here in the schools? And has that issue been explored at all by legal counsel there? And that question is for any of you.
I think Rob, I see unmuted. Yeah, KDE contracts with some of those vendors to do those billings. So I'll defer to KDE on this question.
Yeah, probably not prepared to answer that question at this time. Of course, we'll utilize our Office of Legal Services if we need to pursue anything related to responsibility of our vendors. But we're kind of at the point where we're still looking at the audit itself and trying to vigorously defend that at this point in time.
Okay, thank you very much. Appreciate your time. I'm sorry, Representative Moser has a question. Remotely. Representative Moser, you're recognized.
Thank you, Mr. Chair, and thank you for this discussion. I'm a huge fan of school-based healthcare centers, and it's always better to have these sorts of discussions to understand really the model. I kind of assumed that telehealth would be rolled into this program, so it's good to hear that is being addressed. And I understand that this is a really beneficial program. I thought Representative Wilner was going to ask this question, so that's kind of why I hung back. You were talking about the period of time that the audit took place from 2009 to 2014, and I just wondered what sort of, were there specific changes that were noted in 2014 that led to changes in the billing and coding, and has this been corrected? Is there a firm sort of oversight now in place, or is this something that is being established?
So from a Medicaid perspective, I know that in 2007, there were some changes at the federal level related to school-based services, and I believe that led to some of the changes that we were making, for example, for the random moment time study, those sorts of things. We have worked diligently. I do believe that we have a good plan in place. I believe that our oversight is good. And I would defer to KDE if they want to add anything else. But I think, as Robin had mentioned earlier, there were about 10 states, I think, that had similar audits, and based on the findings, and Kentucky was not included in those 10 audits, but based on findings from those previous 10 audits, the HHS OIG expanded to other states, and Kentucky was one of the states that they chose for that audit.
Thank you, Commissioner Lee. I think the random moment time study seems to be the focus right now. And then as information is pulled, just to give you one example from the findings from the OIG related to duplication of service providers. And so, or people that are providing a service, we might have two people, and I'm focusing under administrative claiming at this point. We might have two people in two different school districts at two different schools that might have the same name. Let's just say, I'm going to use, Mary Smith. And so they were saying we were duplicating services because there were two Mary Smiths performing services. So that would be like one really small example of what they said we were not doing correctly. So what we did as a result of that is really work close with our vendor partner to make sure, because each of our school districts, if you're an employee in a school district, you might have Mary Smith at the name of the school district, kyschools.us. And so you would not be able to put in two emails that said the exact same tagline. That seems to me, it may be the same person that is duplicating services. But if you have two different districts that are identified in that email address, then that further supports that it's two different individuals providing that service, even though they may be at the same time. So it's that type of thing. Some of them are technology things that we've worked on with our vendor partner to try to correct so it doesn't add to confusion. But it doesn't necessarily mean that it was incorrect or duplicates were as a result of this audit. So that's just one small example of things that we're trying to correct from a vendor partner relationship.
Okay, thank you. I appreciate that. And, I guess that would lead me to another question about, as Senator Meredith said, having some questions about the vendors. And has there been an internal audit of an analysis of kind of the billing services using vendors versus an MCO? And is there an RFP process? What does that look like?
There has not been an internal audit that I'm aware of by the Department of Education on this program, at least that I'm not familiar with one.
Okay, I'm just wondering if it would make sense to take a look at some of that. Maybe it's complicated, but if it's a way to streamline some of the oversight and assist with the process, if we have one vendor versus 3 or 4, getting back to streamlining those services and really being efficient, seems that it would be a prudent use of taxpayer dollars. Thank you.
Thank you, and thank you, Commissioner and Associate Commissioner. We'll move on to our next topic, Medicaid reimbursement for ambulance services. Troy Walker, the president of the Kentucky Ambulance Providers Association, is here in the room with us. If you'd make your way to the table, and we will if you'd introduce yourself for the record, and then we will proceed. Turn until you get a green light. Yeah, pull the microphone.
Okay, thank you. I'm Troy Walker. I'm the president of the Kentucky Ambulance Providers Association. I appreciate y'all inviting us to here. I heard you had some questions as far as the ambulance industry in Kentucky. I've been the president for Kentucky Ambulance Providers for 3 to 4 years now. I've been a director of an ambulance service in Muhlenberg County, Kentucky for 30 years in December. So I'm excited to get up here. I'm excited about the invitation. Excited to give you some information that you need to make y'all's decisions.
Sure.
So a little bit about Kentucky Ambulance Providers Association. We are across the state. We have 145 members, air medical and ground ambulance, and about every county in the Commonwealth we have representation at. So definitely the largest and only association. We're not a governing body for the ambulance industry by no means, but we do have a lot of membership and a lot of wealth of knowledge, a lot of experience about ground ambulance services. I'm going to refer to my notes. I apologize. I'm not a public speaker. I'm a paramedic of 30 years, so I can climb in a car on the side of the road and not think a thing about it, but talking in front of you guys, that's stressful.
I understand.
So, but I think the biggest thing to the questions about reimbursement and the cost to do business as an ambulance service in the state, you got to understand a little bit about the ambulance industry. The ambulance service is new. Compared to fire and police, other medical or other responders, they're hundreds of years old in their professions, and ambulance industry is only 40 to 50. So we're still learning and growing. As far as the ambulance industry, we're the only ones that transport patients pre-hospital. Fire and police, nobody does that. A lot of people don't realize that the ambulance industry is not an essential service in the state of Kentucky, like fire and police. And a lot of that, the reason I'm talking about that is because it's fixing to bring up my next topic is what types of ambulance services do we have in the state? And that's one of the reasons. Without being an essential service, we have to look at other means to manage and fund these ambulance services. So in the state of Kentucky, we have 4 types of ambulances, or ambulance structures, business models you might. We have city, county, municipal-based services that are whether a physical court or someone, the court system or city has taken on that responsibility. We have hospital-based ambulance services where the hospital, like myself, I'm a hospital-based ambulance service that's taken on the responsibility. You also have the fire services that sometimes take on the ambulance service side. And of course, then we have the private industry. When it gets to talking about the cost of service for an ambulance service to go per run, I guess is about the easiest way to look at that. A lot of things go into cost per run. Of course, if you have the county services or fire-based, you have to deal with state retirement, hazardous duty retirement, and that seems to be the more expensive cost per runs is the fire-based services and the county-based. We average, just looking out across some surveys that different people has done across the state, between $400 and $1,500. It's a wide range of costs per run for ambulances because of those topics. You know, retirement stuff's expensive. So if you have a private industry service that doesn't have to have the state retirement or has a duty, they can do this a lot cheaper. But there's a lot of other things that go into that. A lot of other responsibilities for ambulance services, fire-based, for example. Every ambulance service by Kentucky Board of EMS regulations requires us to be able to extricate patients out of car wrecks, jaws of life, things like that. We're responsible for that. Fire-based service might have to do that simultaneously. They're doing both at the same time. So they might have to have a bigger, more expensive ambulance to transport the equipment to need, to haul that. It might be a $400,000 ambulance that they use. Whereas I'm fortunate in Muhlenberg County, I have 9 great volunteer fire departments to handle the extrication for me. So I can get by with a $140,000, $150,000 ambulance. So that's just things that contribute to the cost per run, I guess. So between $400 and $1,500 per run. Is there any questions on the cost per run that you have? Or?
Would you like to, I know you're a constituent of Representative Prentice,
yes.
So she may want to make some comments.
Well, he's not finished. He's in the middle. So yeah. I'll wait till he finishes.
Okay.
Yeah, okay. That's fine.
Okay. We jump in sometimes up here. Go ahead.
That's all right. All righty. Well, I think the biggest thing is for Medicaid, and this is honestly for the state of Kentucky, we're celebrating right now. Yes, our reimbursement for Medicaid runs is low, and there's issues with EMS or ambulance services in the state of Kentucky. Kentucky Ambulance Providers Association is fighting that. We've got some different ideas out there. I'm tired of kicking the can down the road. It's time to fix it. And that's something I've been wanting to do for the last 3 years. I have some things that we're looking at that we're wanting to change. The biggest thing is getting some more reimbursement for our ambulance services, because we can talk about not having ambulances and non-emergency transports and education and all the different things for our EMTs and paramedics, and that's all good. But if we don't have the pay, if we don't have the money to pay the employees, it's all mute and void. So what we're working on, what CAPA has worked on for now 6 to 7 years, is House Bill 8, and we finally passed that. It was passed last year. It started January of this year. House Bill 8 is making a huge difference for our ambulance services in the state of Kentucky, and we finally got our first payment in July. We have not made the assessment fee payment yet. That's coming up here in the next 2 weeks. So I would love to have been able to come and give you a lot of data and hard data on that, but we're still right in the middle of it. Prepared to give you just an idea of EMS and what we go through in the billing and what we had before House Bill 8. But hopefully here in the next month or two, I would love to come back with real hard data after we've been able to make the assessment fees and payments and things like that. And also bring some committee members that have been a part of House Bill 8 from CAPA. Both of my members from my legislative and reimbursement committee were on vacation this week, so that's why I'm here today. So, but no, I'd love to come back and give you hard numbers after House Bill 8, the full thing is in effect. So, but just a little bit before, I think before we talk about the Medicaid, we need to understand ambulance billing. Ambulance billing is a bulk billing. We do a base rate. We don't charge individually for items used during an emergency run. We actually charge base fees. So we have about 8 different base fees. These base fees they're either, the levels are emergency and non-emergency, but also advanced life support and basic life support. And there's just different variations with those 4 things in mind. So there's about 8 different base fees in all. So to compare Medicaid, to give you the idea of the rates and why we had to look at House Bill 8, let's just look at just an emergency run, just a simple emergency run. We charge about $899 for that. Medicare allowable for that run is, we put $574. That's the max. There is a minimum also. They've separated it. Medicare does 2 different emergency runs between BLS, or basic life support, and advanced life support. It starts at $397 and goes to $574. And I failed to get that into that document that I handed out. So, but Medicare allowable is there. Our Medicaid payments for an emergency run, though, is $110. That's all we get for any type of emergency run. There's no differential between basic life support and advanced life support. It's simply emergency is $110. Now we do get for Medicaid, we do get a mileage fee added on to that. So we can get reimbursed for $4 a mile. That's loaded miles only though, and doesn't count for all the other mileage for the ambulance. So now non-emergency runs is a flat $82.50. So that's our current reimbursement for Medicaid prior to House Bill 8. So that was some of the reasons. As you can see, knowing what our average charges or cost is per run, that's what we have as far as reimbursement for Medicaid. So, but I don't want to be a Debbie Downer here. Medicaid has been excellent to us in CAPA as far as getting House Bill 8. Like I said, we've been working for 6 years, and to get House Bill 8 passed, we had to have 100% of our providers across the state of Kentucky on board with House Bill 8. It's not something we could just change. So it's been a fight for the last 6 years. We've done a lot of travel, and I put a lot of miles on the road going to different services and getting people to agree with House Bill 8. So Medicaid has been with us from the beginning since we started our venture into getting House Bill 8 passed. Mr. Steve Betchel from Medicaid has met with us, and he's currently meeting with us every single week. What can we do for the process? What can we do to make it better? So Medicaid is definitely, kudos to them. Definitely not here to fight with Medicare. They've been our ally, and we really appreciate it. So as far as the post-House Bill 8 implementation, you can see as the paperwork suggests there, for that $110 run that we was getting for emergency runs, we now have an added $358 per run, which brings our total to $468 now for an emergency run. Yeah, that's not over some of the Medicare allowable, but it's a lot better than what we was getting, and it's made some big changes across the Commonwealth with our ambulance industry. There's a lot of services that was really struggling that are now able to do and hire and raise rates. You know, one of the biggest things when we was looking at things to do for the ambulance industry, when you have EMTs and paramedics out here making $11 an hour, but then you have people, you know, working fast food restaurants wanting 15. You can't bring in staff making $11 an hour. So just in the last 2 months, I've seen multiple services across the state raising their rates, especially for paramedics and EMTs. So I know we was looking at a lot of service from a starting pay of $14 an hour for a paramedic. They're now $18 and $19 an hour. That's what's going to bring people into the industry, and it's going to keep going up. There was already a national shortage of paramedics in the state, so this is going to help maybe bring people into our industry. So that's where we're at with House Bill 8. The numbers, the 468 is a total now for reimbursement from 110. The non-emergency, which is a small portion of transports for Medicaid, they did double that almost, increased it by $85 to now it's $167.50, where it was just $85 for a transport. So that's kind of a summary. I know it's a lot, but y'all had a busy day. So,
well, thank you very much, and that's very informative. And to go from 110 to 468 is a significant difference. So you can see
with no cost to the state,
right? The difference under House Bill 8. I'll recognize Representative Gooch, who had a comment.
Thank you, Mr. Walker, for being here. I'm kind of glad you're here to explain to me a little bit about House Bill 8. I recently got a call from one of the local municipals that have their ambulance service. They have firemen and all the firemen are EMTs, and all the EMTs are firemen or whatever. And they had gotten a letter from the state, and the letter pretty much said that because of passage of House Bill 8, and there was, I guess they were probably showing them, how much of a tax they were going to pay. And I think for my city, it was about $20-something thousand. And so their first response was House Bill 8 was passed, and we're going to be charged $20-something thousand more a year tax to the state of Kentucky. But I think, is that a provider tax that is going to be matched for Medicaid reimbursement, or?
Well, this is an assessment, and this is where I really wish I had some of my people that's been on the meeting, but I can answer a little bit. It's an assessment based off your total runs, but the good thing about it, and I don't know what their numbers would be, and that's something, honestly, later I can get with you and look at the numbers, but my service is, paying $12,000 to $15,000 in itself, but we're getting $300,000 before that that will be paid extra that we've never had before. And the good thing, the way we set this up is we worked with it for a long time, the committees did, and they will actually get 3 payments from this assessment from House Bill 8 before they have to pay anything. So that's the good thing. It was made like that for that because there's services that can't afford to pay that. So you will get the money, or the service will get the money prior to have to pay that 5.5%, into it. So.
Okay, just to follow up, I think that was important. Is they didn't understand that. They were looking at, we're going to get a bill for
Right.
$24,000, and we can't pay that. We're not making money on our ambulance service already. And I had done some inquiries for them, but I really hadn't gotten the answers that I really needed in order to be able to respond.
Right.
So thank you for
yes,
for
and
that. So they're
please,
going to get
afterwards,
more money as a result of this than what they're going to be paying.
Yeah, it's been a step. It's been right now, the net right now for the state of Kentucky with House Bill 8 is $47 million that's coming to the EMS industry across the state. So that's just as an idea.
Representative Prenti.
Thank you, Mr. Chair. And I'm just real proud to have Troy here. He is a constituent of mine. He's very passionate about this work. The reason I brought the issue was the very same reason Representative Gooch was talking about, is that I had someone from Madisonville, their ambulance service was going in the red for providing this. He was not aware of this. And when I went to the Madisonville City Council meeting last month, one of the board members was there, and they said this was already kicking in, so his answer was taken care of. But I would love to have him back and report on the benefits of it. I was just going to ask you, so your provider fee, and you've kind of answered it in saying what you've kind of answered already, but the percentage of the provider fee versus what you're getting back, what's the?
Oh, me.
I mean,
it's we're paying a 5.5% off of every emergency run but then they reimburse us a little over 200% off of our Medicaid emergency transports.
Okay.
So, and I know I've probably messed that up, and that's the numbers part that I need the detail and the experience for, but it's 5.5%. Yeah, it's significant. So, yes, it's almost 3 times what we was getting, and it's a lot of Medicaid patients, as everybody knows in the medical field. So, it was already struggling, but this right here is a huge boost to the EMS.
Okay. Thanks for your work, and thank you, Mr. Chair.
You are welcome.
Being here.
Co-chair Meredith has a comment.
Troy, appreciate your testimony today, and just a quick clarification question for you. You said during your presentation that ambulance service is not an essential service in Kentucky. I think what you meant was it's not identified as essential service.
Okay. Yes,
you
there
certainly
you
don't
go.
feel it's a non-essential service, but it's not identified as an essential service. Did that pose you any problems during this COVID crisis, but not being identified as essential?
Different areas have said yes, it's hurt. You know, what that involves is getting some federal money coming to these services that there was not allowed to get. In my county, I didn't have much of an issue, but a lot of our county-based services and different things, yes, that hasn't been a part of it. So the federal funding is important to a lot of services, but there's a lot of EMS services that can't access that money. I'm not allowed to. As long as I have a hospital in my name and an association with the hospital, I'm not allowed to any federal funding, fire grant money or anything. So that's where the ambulance industry struggles, to be honest with you. And that's why it's important. One of those things we need to work on.
Troy was very kind to bring that to my attention, and I was almost shocked when he told me that it was not identified as essential, and think it certainly should be. And you're right, I think we need to do some work. But you also mentioned that you think there'd be value if there was a ambulance service TAC. You want to talk on that just a little bit?
Yes, with some things going on with our CONs and different things like that, it was brought to our attention about the MAC committee and being able to form. And after looking into the MAC, I was new to that. And that's actually why I come and talk to Senator Meredith. After listening to some of the committee meetings, I thought, well, why does the ambulance industry not present and have a TAC? And that's something we need to work on. You know, shame on us for not knowing that earlier, but now's now, and we're going to do everything we can. I would love to have a seat at the table and have a TAC set up so we can work on some of these issues.
Well, thank you, and thank you for the education today. That's all I have, Mr. Chair.
Thank you. We have Representative Wilner remotely. You're recognized.
Thank you very much, Mr. Chairman. And thank you for the presentation, really helpful, and great to hear that, that you guys are going to be at the table and solving some issues and questions and concerns. And I have a couple of concerns that have been brought to my attention. First one from some of our mental health advocates across the state. And I'm hearing just, anecdotally that ambulance services are telling people that they do not have to transport patients with mental illness, and that there are times when there are patients in a mental health crisis and they're being transported to a facility without a psychiatric unit available. So I just wanted to raise that issue. We know that so many folks across the state who suffer particularly with severe mental illness are Medicaid patients. So it seems something appropriate to raise with this committee. And I'm curious if that's a concern that you're aware of, if that's anything you've heard before.
Yes, thank you for the question. We are working on, I was mentioning just briefly, several issues in the state is involving the ambulance industry, and one of those is non-emergency transports, whether it's interfacility going to another facility for service, behavioral health. There's different things that fall into the category of non-emergency, and most of the problems across the state, I'm not going to say across the state, we have some few key areas that are really having issues, and it's staffing. The ambulances are being used more and more for whether it's hospital or mental health and just different things. Long-term care facilities is also having issues. It's not the number of ambulances we have to respond. It's the staff to put in them. And we've got to bring more people to the industry to be able to handle those runs. And we've got 2 or 3 things out there that would help that problem. House Bill 8 was the first one, a major one. There's some education we have to do, but I think we also have to get on board. Medical necessity is the key for the ambulance industry when it comes to billing practices. They have to reach a medical necessity. A lot of the medical necessity that we have to go by doesn't match what our hospitals and some behavioral health and things like that, they just don't match. So in our industry, it's not paid for. It's not a medical necessity, but people are needing that. And I think that's one of the big things that we also need to do as the ambulance providers is address some of these medical necessities and try to match up the need, I guess, for the ambulance services with what's medically necessary to get these paid for. But there is different now as far as certain services go in certain places. People have their own rules and guidelines, but I think as a whole we need to look at medical necessity for Medicare standards and work on those and get them to match what's needed now, especially with behavioral health.
Thank you.
Representative Prenti.
To follow up on that, Troy, the cost of transporting someone who might not be bleeding or have a heart attack with a mental health issue, could there be a smaller vehicle that wouldn't cost as much? Could there be different vehicles to decrease the cost? I'm just thinking out loud
We're
here,
set by standards from the Kentucky Board of EMS. We have to have certain things. The ambulance, now we do have smaller van type ambulances, but there's things that they got to have on board to be a licensed ambulance service. There's I don't know, there's things we could probably look at, but as far as us, the van type ambulance is about as small as we can get. But still, it's having the staffing to
Gotcha.
to do that.
Thank you, Mr. Chair.
And also the reimbursement piece.
Well, thank you, Mr. Walker, for your presentation. I really enjoyed it, and I think I'd be remiss if I didn't recognize our former colleague, Representative Rothenberger from Shelby County, who was always in my office talking about these issues, and it was always a proud EMT. And we sure miss him here in Frankfort. So thank you for your presentation.
Thank you.
And our next presenter, Barriers to Behavioral Health Services, Gretchen Davis, the Chief Executive Officer of the Opportunity Center of Muhlenberg County. Is she remote? And she's here remotely, so.
Thanks, Representative Prenti, for inviting me to come and share. I have been doing mental health services for an agency called the Muhlenberg County Opportunity Center. When I became director there, I'm a retired school teacher. I taught special ed services some in my days of teaching. And when I went to the Opportunity Center, it's a center for intellectually impaired adults. And it was a sheltered workshop. And basically, I know we all are trying to get away from a sheltered workshop because there's nothing else for our population of intellectually challenged people. Basically, right now, they can go to school until they're 21 years old, and then there's just not a whole lot out there to offer. Another challenge is that there's 10,000 people on the waiting list for the SCL waiver and the Michelle P. waiver. So in Muhlenberg, whenever I came to Opportunity Center, out of about 50 clients that were coming there, only 5 of them were on a waiver. And so we had the rest of our people weren't being served in any way other than they were a sheltered workshop, putting pieces in a bag and labels on bags. And, that was their day every day. So as I started trying to figure out programs for them, I started to realize that so many of them had other issues, be it physical health issues, but a whole lot of mental health issues. And so I started talking with parents. I started talking with other agencies and realized that most of them had a co-occurring mental health disorder that went along with their intellectual disability. And so I was informed by someone. It was just kind of an accident that I even found out. I was introduced to regulation AAR 907 for being able to become a behavioral health multi-specialty group under Medicaid. So I studied, and I had absolutely no experience in any of these types of things, but I learned. I made some mistakes along the way, but I still learned that I could do this. Today, we have about 30 of our clients. We've just been able to bring them back in May after being out for 15 months because of COVID. Of course, their behavioral health is more challenged than ever right now, but we do what's called comprehensive community supports. And on one of the handouts that I gave you, I just kind of addressed what that was. And basically what it is, it's meeting a lot of their needs that they've never had met. It helps their parents. It's just, I see changed lives with this program because with community supports, they have community support associates that is with them every day, working with them on their treatment plans. This is overseen by an LCSW, and I'm seeing them live their best lives. I appeared before Medicaid Oversight back in the fall of 2018, and Representative Prunty helped me out then because of the things I was facing with Medicaid. I did not understand so much of the regulations. But I truly, after I spoke, I got some help from different people, and I've been able to go forward. And like I said, although COVID hurt, we still we're back and we're serving these people again. Some of the roadblocks that I faced with this, and I'm just facing, I faced a huge one yesterday. The main trouble for me is with the MCOs because they're all different. I read my Medicaid regulation Bible. I study everything to make sure I'm doing everything in compliance, but there'll be a challenge with an MCO every month that I'm constantly having to deal with. The main thing that I'm dealing with, this happened yesterday, was that most of our people with intellectual disabilities are Medicare and Medicaid. And so since we've started back and started billing, some of the MCOs are denying these claims because they're saying that I didn't bill Medicare first. And I don't have anything with Medicare. I don't have any contracts with Medicare. I don't have any providers for Medicare. So now, I've spent a huge amount of time yesterday just on the phone with different people in Medicare and Medicaid. And if any of you can guide me in the right direction on this, I would appreciate it so much because I don't know what to do. Now, this has never happened before to me, and it's never been a problem before. So that's one of my major issues. The other major issue that I faced getting started back up is we have never asked for Medicaid transportation for this program, but I'm Muhlenberg County, and we also have clients coming from Hopkins County. To be able to transport these clients, they're having to pay about $50 a day through PACS. That's our only transportation system. So their families are going to be out a huge amount of money every day just to come to get these mental health services. And I reached out and trying to figure out what we can do to help them. And I was told that what I was doing was unprecedented and that they didn't know if they could help me out or not because this was just, they really didn't have any reason other than to tell me it was unprecedented. But the thing is, we've started a program that helps people, and it may be unprecedented, but I'm following every guideline out there in our community supports to help these guys who basically can't help themselves. So that is my main concern with what's going on as far as Medicaid goes right now. My other concerns, because I've learned so much, and because Muhlenberg County is very rural and we have very little mental health services available, I am starting my own clinic, Eliminator Behavioral Health Services. And my main problems going forward are with the MCOs. And on my handout, I gave you a list of things that I'm facing on that end. And I've done all the work myself. I don't have the money to hire anyone else to do this as I start this new business. But it's very, very hard when you have 5 MCOs that aren't on the same page with you. When I think that everybody should be following what I'm told to follow Medicaid, and they don't. That's been a problem for me all along too. So, any help that you all can give me, any questions that I can answer, and I would appreciate, because I feel like this is such a need for our community. I've had so much good response of people so excited that I'm going to be providing some of these things. And, just general insurance, commercial insurance is not going to pay for case management and peer supports and community supports. And those things are huge for our Medicaid population. I just really think I even have my court system wanting to partner with me because they have so much trouble with so many juveniles, and people are coming to the courts, and a lot of it's just based around mental health issues and how do we address it. So my passion is for my community and to help the people who need help that don't know where to turn.
Well, thank you very much, Ms. Davis. And I'm looking at the sheet that you provided our committee, and I haven't had a chance to read through it all, but I do appreciate you sharing with us your experience with the various MCOs, and I do want to recognize Representative Prunty on this.
Yeah, thank you. Thanks, Gretchen, for presenting today. I can't say enough good about what Gretchen is doing in our community. I know I heard her speak one time, and she said, at the Opportunity Center, she could service a handful of people, but tons more kids graduate from high school every year, and where are they in the community? And the support of the community is so great. But I mean, her issues with getting the providers through the MCOs, we hear this story over and over and over again. So I just wanted her to come and tell her story as a witness to the ongoing problems that we have the MCOs. And I know that lives are being changed through the work that she's doing. So I appreciate y'all allowing her to present. And Gretchen, thank you. And any help that y'all can give me to give her, I would appreciate. But I know that it bears on to what Senator Meredith has said so often about the MCOs having so many and all the different. It's just a story we hear all the time. So, thank you, Mr. Chair.
Dr. Alvarado.
Thank you, Mr. Chairman. I'm just maybe we could provide this information to the commissioner, and then can channel it all to, because we often get comments from a lot of these providers, these MCO providers, who want to meet with us and talk about issues. So once you make them known to us, we can forward it to them, and also to Commissioner Lee, and see if they can get any responses back for you on these items that you've listed out for us. This is very helpful, actually. So just wanted to comment.
And a couple of things have been resolved in the last couple of days. Still a lot of trouble with the Passport Molina. And, I realize that during this COVID time, it's hard on everybody. And I understand that. I understand a lot of people are working remotely, but some of these things have gone on for months and months and months and haven't been addressed. So, it's just, and it may be just totally something that can't be resolved, but I just feel like I've got to try to help all the people that I can in my community.
Representative Prenti.
A couple years ago, I had it wasn't Miss Davis, it was another constituent who were having issues with the MCOs, and Representative Bentley and I made a tour to some of the MCOs to their office. They about croaked when we walked in the door and wondered what we were doing there, but I'd be willing to do that again if anybody wants to go with me. So, thank you, Mr. Chair.
We always like field trips here in Frankfort, so thank you so much, Ms. Davis, for your willingness to come to the committee, and for Representative Prenti inviting you and bringing this to our attention. And I think that Senator Alvarado's suggestions are exactly what we need to do here. I know I'm contacted often by MCOs as to what's right, what's wrong, what are you hearing? And so this is, I think, a roadmap, at least from your perspective, as to some of the problems that you have had. So I do want to remind the members of the next meeting will be on Wednesday, September the 22nd at 3. And if there's no other business to come before our committee, we will stand adjourned. Thank you very much.